Hello, everyone, and welcome to our webinar, Trends in the Magnitude and Prevention of College Drinking Problems. I'm Cindy Clowner with the Higher Education Center, and I'm so excited to have Dr. Ralph Hingson from the National Institute on Alcohol Abuse and Alcoholism as our presenter today. Before we begin, we just have a few housekeeping things that we would like to share with you. If at any time you have a question for Dr. Hingson, he will answer those at the end as time permits. You're welcome to enter them into the questions box in your control panel on the right-hand side of your webinar. The Higher Education Center uses a membership model to support its services, and we encourage you to learn more about our membership. Premium membership provides unlimited access to our Screen U alcohol, prescription drug, and marijuana program. Screen U is a web-based SBIRT program, screening, brief intervention, and referral to treatment. You'll see additional membership benefits listed as well. If you would like any more information about becoming a member of the Higher Education Center, I encourage you to reach out to us at hecaod@osu.edu. And now I'd like to introduce to you our presenter, Dr. Ralph Hingson, who is the Director of the Division of Epidemiology and Prevention Research at the National Institute on Alcohol Abuse and Alcoholism, or NIAAA. Before joining NIAAA, he was Professor and Associate Dean for Research at the Boston University School of Public Health. He has authored or co-authored 170 research articles and book chapters, including studies of the effects of raising the legal drinking age, zero tolerance laws for drivers under 21, 0.08% legal blood alcohol limits for adult drivers, comprehensive community programs to reduce alcohol problems, early drinking onset on alcohol dependence, traffic crashes, unintentional injuries, and physical fights after drinking, as well as assessments of morbidity and mortality associated with underage drinking by U.S. college students ages 18 to 24, and interventions to reduce both underage and college drinking. Dr. Hingson currently serves on the World Health Organization Coordinating Council to implement the World Health Organization's Global Strategic Plan to reduce the harmful use of alcohol. In recognition of his research contributions, the Robert Wood Johnson Foundation honored Dr. Hingson in 2001 with its Innovators Combating Substance Abuse Award. In 2002, he received the Widmark Award, the highest award bestowed by the International Council on Alcohol, Drugs, and Traffic Safety, where Dr. Hingson was a past president. In 2003, Mothers Against Drunk Driving instituted the Ralph W. Hingson Research and Practice Annual Presidential Award, with Dr. Hingson honored as its first recipient. In 2008, the American Society of Addiction Medicine conferred the R. Brinkley Smithers Distinguished Scientist Award to Dr. Hingson. In September of 2017, Dr. Hingson will receive National Institute of Health 2017 Director's Award for his role as a member of the Surgeon General's Report Team for the recently released Surgeon General's Report on Alcohol, Drugs, and Health. Dr. Hingson, it's a pleasure to have you today.
Well, thank you very much, Cindy, for inviting me to do this presentation, and I appreciate all of the people in the audience taking the time out to hear about this. We're going to focus today on the magnitude and trends of college drinking. I should mention that there are a couple of very good review books on this. Chris Correa on college student alcohol abuse, and George Dowdell has a book on college drinking, reframing a social problem and changing the culture of college drinking. Misuse of alcohol by college students is really part of a larger public health problem that our entire nation experiences as a result of alcohol misuse. According to the Centers for Disease Control and Prevention, alcohol misuse is the third leading contributor to preventable deaths in the United States. Annually, there are nearly 90,000 alcohol attributable deaths. The majority of those deaths are acute deaths, either injuries or poisoning, nearly 50,000 of those. Those tend to affect younger people than the chronic disease attributable deaths, and so they actually account for twice the number of preventable years of life lost as the chronic disease deaths do. If we look at the major types of acute deaths, we can see that motor vehicle traffic deaths lead the way, but poisoning, overdose deaths are rapidly catching up to the alcohol attributable motor vehicle deaths, and that's something that we're going to talk about in a minute. The Centers for Disease Control has estimated that alcohol misuse costs the United States about $250 billion a year. That's the equivalent of about $800 per person per year. And what's important to note is that the majority of those costs are borne by people other than those who engage in alcohol misuse. It's paid for at the federal level, at the state level, and at the local level, and people other than the excessive drinkers also account for those costs. 3/4 of the costs result from binge drinking and about 10% from underage drinking. NIAAA, the National Institute on Alcohol Abuse and Alcoholism, has, based on epidemiologic studies, assigned or identified what they call low-risk drinking limits. These are limits that if you drink beyond that, the risk of injury and illness and developing alcohol dependence increases sharply. It's not to say that if you're drinking below the limits that there's no risk. There is some risk of traffic crashes begin with the first drink. Very low levels of alcohol use increase the risk of breast cancer in women. So there's not no risk. But basically the limits are if on a single day, if men drink more than 4 drinks in a single day or more than 14 drinks in a week, and women drink more than 3 drinks in a day or more than 7 drinks in a week, if they drink higher than that, then they're getting into the risky zone. And to put it in perspective, for men, if they drink 5 or more drinks over a 2-hour period, or women 4 or more drinks over a 2-hour period, they would reach blood alcohol levels typically of 0.08, which would make them legally intoxicated in every state in the country. So basically, what NIAAA is saying is don't drink to intoxication. Now, the limits don't apply to people who are underage, who are pregnant women, or people who are taking drugs that are contraindicated when alcohol is present, people who are driving motor vehicles or operating machinery, or frail elderly people. This generally applies to healthy adults. When we, at the time that NIAAA released these limits, when we looked at the population 18 to 24, we found that about 9% exceeded both the daily and weekly limits. It's about 20 million people. And that's in the entire population of people who are 18 and older, but 25%, a much higher percentage of those who are 18 to 24 exceed those limits. People who are 18 to 24 account for 16% of the population 18 and older, but 1/3 of those who exceed the low-risk limits. The young people 18 to 24 are also much more likely to experience alcohol dependence. In fact, the age group that's most likely to meet alcohol dependence criteria are the 18 to 24-year-old population. They're 16% of the population 18 and older, but 43% of those who meet alcohol use disorder criteria. For these reasons, this institute has been very much interested in how we can go about preventing college-age drinking. Back in 1998, the Institute established a panel of 25 college presidents and 25 researchers to look at the magnitude of college drinking problems and identify what we knew at the time would be effective in preventing those problems. That was updated in 2008. Both the initial report from 2002 and the update from 2008 were sent to every college president in the United States. And the 25 background papers that led to the report and the report itself were posted on NIAAA's webpage, www.collegedrinkingprevention.gov. That website and the information about college drinking has received an enormous amount of attention since the report was first published in 2002. The latest estimate that I've heard is that there have been over 400 million hits on the website, people inquiring about college drinking. So obviously it's a topic that is of great concern to the nation. When the report came out, I wrote the background paper on the magnitude of the problem, and I dedicated that article to a young man named Jonathan Levy. Jonathan was a freshman at Radford College in Virginia, and he and some of his friends decided that on Halloween that they were going to go party hopping, that they would go from one party to another. After being at the first party that they attended for about 20 minutes, they decided it was time to move on. I don't know if Jonathan realized it, but the person who was driving the vehicle that was going to transport him from one party to the next had been drinking. And on the way to the second party, he lost control of the vehicle, crossed the center line, and crashed into an oncoming car. Jonathan was, the driver and Jonathan were killed instantly in the crash, and another student from the same college, Travis Stedman, was in the rear seat. He was left unconscious for over a week, lost his left eye in the crash. And ironically, the vehicle that they crashed into was being driven by a woman named Dr. Margaret Moore, who was a professor at the same college. She too was killed in the crash. Only a month before she'd received her PhD in computer science, left 4 children orphaned as a result of that crash. So I think the point that this illustrates rather graphically is that college students who misuse alcohol don't only run the risk of harming themselves, they can harm other people. And that is an incredibly important leverage in trying to work with colleges and their surrounding communities to convince them that steps need to be taken to try to address this issue. After the report was released, NIAAA, the National Institute on Alcohol Abuse and Alcoholism, issued a request for applications. They had a financial set-aside where they encouraged colleges to test out new interventions to try to reduce college drinking. They had an 2 independent competitions, one for investigators, scientific investigators, and one for the colleges that were going to try to identify and test out new interventions. That was a very productive exercise. The various investigators and college representatives met annually with staff from NIAAA to share ideas and to try and standardize measurements and so on, and ultimately led to a special issue of the Journal of Studies on Alcohol and Drugs, where the major findings of those studies were reported. Now, what I'd like to do to begin this talk is to look at what's been happening over time in terms of alcohol-related unintentional injury deaths among college students and the percentages who were engaging in binge drinking and driving after drinking. If we look at the unintentional alcohol-related injury deaths, and these are estimates. We have solid data on how many alcohol-related unintentional injury deaths there are among 18 to 24-year-olds, and we project the number that are college students based on the percentage of 18 to 24-year-olds who are enrolled in college each year. We think that's a rather conservative estimate because college students are higher percentages report driving under the influence of alcohol, and until very recently a higher percentage also reported binge drinking. So back when the first report was released, we were looking at 1998 data, and there were about 1,500 alcohol attributable unintentional injury deaths among college students. That unfortunately increased and continued to increase after the report was released up till around 2005, when there were over 1,800 alcohol attributable injury deaths. The good news is that since then the numbers have been coming down to 1,519 in the year 2014. Because the population of students attending college in the United States has increased, that actually means that there has been, since 1998, a 31% decline in alcohol attributable unintentional injury deaths among college students ages 18 to 24. If we look at binge drinking, it followed the same pattern. Binge drinking increased and peaked in 2005 and then declined in 2008, 2011, and 2014. The peak was around 45%. In 2014, the numbers were down to 37%. Same pattern with driving under the influence. That increased from 26.5% to nearly 29% in 2005, but then after 2005 decreased to around 17% in 2014. So it looks like what were very concerning increasing trends in binge drinking and driving under the influence and alcohol-related unintentional injury deaths among college students ages 18 to 24 have been reversed. Now, that doesn't mean that we're out of the woods and that there aren't continuing to be problems in this age group. We have another article that was published in the American Journal of Preventive Medicine this past May, where we looked at a national sample of over 35,000 people collected by the NIAAA, and there we found that the percentages of people over a 10-year period from, this was in 2013, from 2003 to 2013, who drank at 2 to 3 or 3 or more times the age gender-specific threshold actually didn't change. About 19% of college students drink at 2 to 3 or 3 or more times the binge threshold. That's higher than the overall population, 18 and older, which is about 13%. To put that in perspective, if somebody's drinking at 3 or more times the age gender-specific binge threshold, that means that a woman over a 2-hour period would have to consume at least 12 drinks, and a man over a 2-hour period at least 15 drinks. That type of drinking over a 2-hour period which would prompt people to reach blood alcohol levels of 0.2 to 0.3 on an empty stomach. Even if it was a full stomach, the blood alcohol levels that would be reached would be 0.2 to 0.3. Blackouts begin at a level of a blood alcohol level of 0.2, and medical examiner studies indicate that the typical alcohol overdose death is at a blood alcohol level of 0.36. So that doesn't mean that everybody who reaches the 0.36 is going to die from an overdose, but it means that this is very dangerous drinking. So while there's good news in the Journal of Studies on Alcohol paper that I was just describing, where the binge drinking and the driving after under the influence of alcohol among college students is going down, it doesn't mean that we don't still have a serious problem. And we need to, I think, redouble our efforts to learn about how to reduce these problems and what interventions are the most effective. And so we will, our institute will continue to monitor this, and will continue to try to publicize what types of interventions work best. The next slide indicates, this look at binge drinking, that the group that's most likely to engage in binge drinking are the ones that are of legal age. The college students who are ages 21 to 24 have the highest percentage who engage in binge drinking. Those who are 18 to 20, somewhat less. What's interesting to note, though, in this slide is that in the last year that we're looking at, both among 18 to 20-year-olds and 21 to 24-year-olds, the people who are not in college actually have now have higher binge levels than those who were in college. So that overall, among 18 to 24-year-olds, 40% in 2014 of college 18 to 24-year-olds engaged in binge drinking, compared to 37% of college students 18 to 24. That reverses a trend that had existed for many years, where a higher percentage of college students reported binge drinking than same age non-college students. If we look at this is driving under the influence, and we can see the rather sizable declines in driving after drinking, both among college students and non-college students. Part of the reason that I think that this trend has started coming down since 2005 is that in 2000, Congress passed legislation that would withhold federal highway construction funds if states didn't lower the legal limit down to 0.08. And at that time, less than 20 states had a legal limit of 0.08, but by 2005, all states adopted a legal drinking age, or rather a minimum blood alcohol limit of 0.08. And I think that's helped to bring the driving under the influence down among college students. If we look at monitoring the future data, and let me explain the slide that's in front of you now. In the 1984, most states had legal drinking ages below the age of 21. Research has started to come in showing that when states were lowering the legal limit, or lowering the minimum drinking age, that there were increases in alcohol-related traffic fatalities among those under the age of 21. So Congress in 1988 passed legislation that would withhold highway construction funds if states didn't raise the drinking age to 21. Here you can see a picture with then President Ronald Reagan signing the bill. Ronald Reagan fashioned himself as the ultimate states' rights president. He didn't feel the federal government should tell states what to do. But when he signed this bill, he said, you know, sometimes saving young lives is more important than states' rights. And if we look at what's happened with regards to underage and college-age drinking since the legal drinking age was raised, we can see that the percentage of high school seniors who engage in binge drinking, this is based on monitoring the future studies, looking at the 2 weeks prior to the when these surveys were done, high school binge drinking has been cut in half. In fact, the most recent year that this data was collected, the percentage who reported of high school seniors who reported binge drinking was the lowest ever in the 30 years that the Monitoring the Future studies have been conducted. If we look at people who were older than the 12th grades, 1 to 4 years older, past high school age, there were also declines in binge drinking in that age group, although not as steep as the high school seniors. And even among college students, we can see that there have been some declines in binge drinking over time. The next slide looks at alcohol-related traffic fatalities, again looking at essentially the same time periods of when the legal drinking age was raised, but also looking at when the call to action to reduce college drinking was released. And we can see that there has been a remarkable decline in alcohol-related traffic deaths among 18 to 24-year-olds, a 71% decline that is continuing even after the call to action that NIAAA issued. During the same time period, fatal crashes among 18 to 24-year-olds that didn't involve alcohol went down, but not nearly to the extent as the alcohol-related traffic deaths. So we have made some very considerable progress in reducing alcohol-related traffic deaths. Unfortunately, as we're all aware, during the same time period, drug overdose and drug deaths have quintupled in the United States. We're now up to over 52,000 drug deaths. Most of them are overdose deaths. In 2008, the drug deaths actually surpassed traffic crash deaths as the leading cause of acute death in the United States. There's been a shift from illegal drug overdoses in inner cities to prescription drug misuse in rural and suburban areas, and the opioid constitutes a very large portion of those overdose deaths. If we look at CDC's data on alcohol-related alcohol attributable death, we can see that the annual average of traffic deaths from 2001 to 2005, then compared with 2006 to 2010, shows a sizable decline in traffic deaths, but at the same time, the overdose deaths have gone up 58%. So this is something that we're really quite concerned about. If we look at the National Household Survey of Drug Use and Health conducted by SAMHSA, it's clear that illicit and prescription drug misuse is increasing, and the people who are most likely to engage in those behaviors are binge drinkers. Well, the people who binge drink and combine that with illicit and prescription drug misuse are particularly vulnerable for overdoses. This is a study that was published in the Journal of Studies on Alcohol. Aaron White, who works with me, and I wrote this article. And if we look at people ages 18 to 24, we can see that about a third of the overdose hospitalizations in that age group involved alcohol. Overall, among people of all of ages 18 and older, in 2008, the year that this study looked at, there were 1.6 million overdoses that resulted in hospitalizations, and 180,000 of them were ages 18 to 24. If we look at the preceding 10 years, something very important emerges, and that is that overdoses, hospitalizations that involved alcohol only increased 25%. Those that involved drugs only increased 56%, but those that involved alcohol and drugs in combination increased much more, 76%. If people have co-occurring alcohol and drug problems, their judgment is often impaired, and they're more likely to take higher and potentially more dangerous doses of both alcohol and drugs. And we know that pharmacologically, alcohol can potentiate the effects, particularly of drugs like opiates and sedatives. And people can overdose at lower blood alcohol levels if they have these drugs on board. So I'm not saying that alcohol should be the tail that wags the dog in trying to prevent drug overdoses, but it's clearly an important part of it. And I believe that alcohol's role in drug overdoses is underestimated. The death certificates require that if drugs are on board when there's an overdose, that the drugs involved be listed. There are 3 lines on the forms, and oftentimes those lines get filled up with 3 drugs, even though they know that alcohol was also present. Even that being said, the data would indicate that conservatively 25% of drug overdose deaths also involve alcohol. So alcohol is an important part of this, and it's something that clearly needs to be addressed on college campuses and in their surrounding communities. Now, we've been working with the National Institute on Childhood and Human Development on what's called the Next Generation Study. This was a study of a random sample of 16-year-olds. We began looking at them when they were in 10th grade, and then they've been followed every year. The slide I'm showing you here reports on data when they were 1 year out of high school, which meant that many of them were in college. Some of them were not. This table looks at those who were in freshman and 4-year colleges compared to those who were not enrolled in any kind of college, not in a community college or a 2-year college or any type of college environment. And what we can see quite clearly is that the college freshmen were more likely than their same age counterparts to report risky drinking. They're more likely to drink. They're more likely to report drunkenness, driving after drinking, and so on. They're more likely to report hangovers and missing school and work because of their drinking. And not only were they more likely to report more problems that they as respondents experience because of their own drinking, it appears that they're more likely to experience problems because of other people's drinking, having arguments, property damage, having to babysit other drinkers, having their sleep or work interrupted. So these are secondhand effects of alcohol. And again, another example of why it's important to intervene to help prevent people from experiencing harm that results from other people's drinking. So there's clearly a need, I think, for colleges and universities to try to address these issues, but the colleges can't do it alone. And I say that for a couple reasons. The first is that the problems of alcohol misuse in college often begin long before people are in college. We know from national surveys that the younger college students were when they first began to drink or first experienced drunkenness, the more likely in college that they'd experience alcohol dependence or report driving after drinking or alcohol-related injury or risky sexual behavior after drinking. Alcohol problems begin in high school. According to the CDC's Youth Risk Behavior Survey, which is a national survey, nearly 1 million high school students and nearly 2 million 12 to 24-year-olds consume 5 or more drinks on an occasion at least 6 times per month. So they're drinking to intoxication at least 6 times a month. And these frequent binge drinkers, compared to abstainers in high school, are much more likely to drink at school, to use marijuana at school, and to earn mostly D's and F's. They're much more likely to engage in a whole host of behaviors that put themselves at risk and other people at risk. They're more likely to ride with drinking drivers, to drive after drinking, so they're more likely to be in crashes. They're more likely not to wear safety belts, so where they're in crashes, they're more likely to be injured. They're more likely to carry guns, more likely to be in fights, more likely to attempt suicide, to engage in risky sexual behavior, and take other drugs. And as this slide shows, they're much more likely to drink and use drugs at school. Well, it doesn't take magnetic resonance imaging to figure out that people who are drinking and taking drugs at school are not going to perform as well academically. And in fact, they're nearly 5 times more likely to have earned mostly D's and F's on their report cards in the past year. The human brain is still developing until people are in their mid-20s. And comparisons of alcohol-dependent adolescents to those who don't drink indicate that there are cognitive deficits linked to heavy drinking among high school students. They're more likely to experience decrements in memory, in spatial relations, and executive function and judgment. Now, the early studies that looked at this were cross-sectional studies, and they tended to be pretty small, few numbers. We at our institute have issued requests for applications for people to do longitudinal research to begin looking at young people before they started to drink, and then compare those who developed heavy drinking patterns over time to those that didn't engage in heavy drinking. And one such study I'll report here looked at adolescents. They followed them till ages 16 to 18. Back in 5th grade, those who went on to develop heavier drinking patterns and those who didn't had similar scores in test performance in mathematics and language. But when they were followed over time, after some of them had started to engage in heavy drinking, the cognitive deficits appeared, the memory and the spatial relations, poor language and achievement, and so on, which can clearly affect their academic and occupational performance. And what's important about that study is that they found, I'll go back a minute, they found that even after a month of supervised abstinence, where they referred the heavy drinkers into treatment programs, many of these cognitive deficits persisted. And so that really raises a grave concern. I think that this is an important national problem. You know, there are many studies that link heavy drinking to poor academic performance, not only in high school, so that people are less likely to graduate from high school, but more likely and less likely to get into college or the college of their choice. But there are a number of studies that link college binge drinking to poor academic performance while they're in college. And these are just lists of review articles that look at this. After I prepared these slides, I came up with there was a new study, a fellow by Bamberger in the Journal of Applied Psychology, published a study that showed that frequent heavy drinkers in college upon graduation were less likely to become employed. They had 10% higher unemployment rates than the college students who didn't engage in heavy drinking during college. So there's clearly evidence that heavy drinking is related to poor academic performance and to cognitive deficits. And you know, my concern is that even if people stop these heavy patterns of drinking, that there's opportunity cost. That if they don't do well in high school and don't finish high school, or don't get into college, don't get into the college of their choice, or don't perform well in college, there are residual problems that they may experience throughout the rest of their life as a result of this heavy drinking and its effects on academic performance and cognitive development during adolescent and college years. So all of these data coalesce and indicate that there's an urgent need to expand and improve prevention, screening, and treatment programs and policies to reduce alcohol-related harm, not only among college students, but among people who are under the age of 21 and people who are of similar ages who are not in college. We need to improve our surveillance of alcohol-attributable mortality. We need to get college identifiers on the injury and mortality data, and we need to make sure that all injury injury deaths and poisoning deaths are tested both for alcohol and other drugs. And as I said before, I don't think that the colleges by themselves can most effectively address this. For every 18 to 24-year-old who's in college, there are more who are not in college. So we have a whole culture of drinking among young people that needs to be changed. And as I indicated at the outset of this talk, while we're having some success in bringing down binge drinking among college students, among non-college 18 to 24-year-olds, the percentages who are engaging in binge drinking are increasing and now surpass the percentages among college students. So there's a whole culture that needs to be changed with regard to alcohol and young people. Now, the good news is that since the NIAAA report was first released, there has been a tremendous expansion in our knowledge base about how to intervene at multiple levels to reduce alcohol misuse. We now know that there are effective interventions that can target individuals, such as screening and brief intervention, social norms interventions, web-based interventions, interventions that target the family, that target environmental policy, and comprehensive community interventions that try to implement multiple levels of interventions at the same time. A couple of years ago, NIAAA released what they call College AIM, the College Alcohol Intervention Matrix. And what NIAAA did was they commissioned researchers that we have supported to review the research literature on 60 different types of individually oriented interventions or policy oriented interventions to reduce college drinking. They've reviewed over 300 articles that had been published in peer review literature and have identified what types of interventions at the individual level and at the policy level are most effective and what the costs are associated with it, what the barriers are, what's the quality of research, the strength of the findings, and how one can overcome the barriers. So it's sort of a menu of what works in efforts to reduce college drinking. And these are the individually oriented interventions that they found to be effective, and these are the environmental, particularly retaining the legal drinking age of 21 and enforcing the legal drinking age, and reducing the access through reducing outlet density and increasing the price of alcohol. Now, if we look at the individual level, for many years there has been evidence that screening and brief counseling interventions around alcohol are very effective for adults in primary care. The U.S. Preventive Services Task Force has reached that conclusion, which enables reimbursement for healthcare providers who do screening and brief intervention around alcohol. But it's also been found specifically with regards to adolescents and college students. And these studies that are listed here on this slide, they're not individual studies. These are literature reviews that show that screening and brief intervention is effective with adolescents and college students. Here's some more showing them to be effective. The most recent and perhaps the largest of the two are the last two that are listed. Tanner Smith at Vanderbilt University reviewed 185 studies of adolescents ages 11 through 19 and then adults 20 and older, and actually found stronger reductions in alcohol use among the screening and brief intervention studies that targeted adolescents than targeted adults. And the effects persisted up to a year after the initial counseling. Lori Scott Sheldon at Brown I'll skip over that. It's a Tanner-Smith slide and the results there. Laurie Scott Sheldon reviewed 41 studies of college students looking at 62 individual or group interventions, and found that these screening and brief interventions were so effective that they recommend routine screening of all incoming college students. Well, the average college student in the United States has at least one university health service visit a year. So if this recommendation were followed, then there's a potential to have population level of benefits in reducing alcohol use just by doing the screening and brief intervention. Now, I think, of course, the most effective programs are those that combine multiple levels of intervention. This is yet another study done with college students that show single session screening and brief intervention is effective. There now have been reviews that show that not only is screening and brief intervention for alcohol effective in reducing alcohol misuse, it also reduces driving while intoxicated. People driving while intoxicated, mostly because it reduces their heavy episodic drinking, which would lead them to be intoxicated if they're driving. But that's important because, as I mentioned earlier, alcohol-related traffic deaths are the leading cause of alcohol-related deaths among college students, or at least have been over the last few years. Now, unfortunately, we have an implementation gap. A few years ago, we did a national survey of 18 to 39-year-olds. Two-thirds of those respondents in this national survey had seen a physician in the last year, but only 14% were asked about their alcohol consumption and given any kind of advice about what drinking patterns pose risks to health. And the group that was least likely to be asked were 18 to 25-year-olds, the ones that are most likely, as I pointed out at the beginning of this talk, who are most likely to exceed low-risk drinking limits and to meet alcohol dependence criteria. So precisely the people who should be on healthcare providers' radar screens are not. And we need to work with physicians to increase the proportion of young people who are screened for alcohol problems. I dedicated this article to a young woman named Helen Marie Whitty. I was invited to speak at the 30th anniversary of Mothers Against Drunk Driving, to be the keynote speaker at that meeting, national meeting. And after I got done with my talk, a woman came up to me, this is Helen's mother, and came up to thank me for the work that I do, but she burst into tears because she remembered the loss of her daughter 10 years earlier. Helen Marie was rollerblading in a park when a group of drunken teenagers in a car skipped over a curve into the park and onto the sidewalk where she was rollerblading and struck her and killed her. So it really points out the enduring pain that people experience as a result of underage and misuse among college-age individuals. We have done studies with the NICHD following this cohort of 16-year-olds till they're 1 year past high school. And what we found was that 42% were enrolled in a four-year college. Those who were in college, those in community colleges, and those not in college, three-quarters of them saw a physician in the past year. But only 45% of the college students were advised about health risks linked to drinking or smoking or drug use, which is lower than the percentage of those who are in community colleges or those who are not in college. And only 14% of the college, these college freshmen, who, by the way, are under 21, so they're not supposed to be drinking, only 14 to 15% were advised by either a physician or some healthcare professional working with the physician to reduce or stop drinking, which is a substantially lower percentage that were advised to reduce or stop if they were not attending college. Even college students who reported being drunk 6 or more times preceding this interview, only 30% were advised in the past year by their healthcare providers to reduce or stop drinking. So we need to work with providers. We need to make screening and brief intervention around alcohol routine in university health services, and we need to make it routine amongst primary care physicians as well. Now, why aren't physicians asking college students these questions? Well, it takes time to ask the questions, time to respond. There's a lack of training. That's why NIAAA has developed training manuals about how to do screening and brief intervention and how to respond to adolescents and adults if they exceed low-risk guidelines. There's lack of treatment centers for referral, and there are reimbursement issues. For those of you listening to this webinar, I would ask, how many of you live in states that are listed on this map in blue? And if you answer yes, I don't know if you're aware, but in your state, there are laws on the books that allow insurance companies to withhold medical reimbursement for treating people who've been injured under the influence of alcohol or drugs. Now, if you think about that, that's a terrible disincentive for providers to ask about alcohol and drug use amongst patients who come in for treatment and to record it in their medical records. Now, if you live in the states that are in pink, those states have recently repealed those laws. And it seems to me it's a very important question to find out whether or not in those states now a higher percentage of young people are being screened for alcohol and offered brief counseling interventions. There has been some interest on whether or not screening should be just for alcohol, given this increase in combined alcohol and drug overdoses. There's the National Institute on Drug Abuse and the National Institute on Alcohol Abuse and Alcoholism did a national study where they found that actually the questions that we recommend be asked as part of screening for at-risk alcohol use are also quite effective in identifying drug use, particularly illicit drug use. There have been the literature on screening and brief intervention for drugs is not as widespread or robust as the literature on screening and brief intervention for alcohol. There are a number of studies. In fact, there were 3 very high-profile studies that were published in the Journal of the American Medical Association back in 2014 that found no benefit of screening and brief intervention for drugs. They were very well-conducted, highly rigorous, high internal validity studies, but they all focused on low-income inner-city populations with high unemployment. Many of them are separated and divorced and had psychiatric comorbidity. So the question of, I believe the results were accurate, but the question is, are they generalizable to all populations? There have been a number of other studies that have shown that there are benefits of screening and brief intervention for drug use, and they probably outnumber the ones that show no benefit. The bottom one there actually was done in a low-income inner-city population, very similar to the ones that the JAMA study identified as not having an effect. Emily Tanner-Smith has recently done a very interesting literature review where she looked at screening and brief intervention. 7 studies looked at doing that for alcohol only, and 23 targeted both alcohol and drugs. Most of them were randomized trials and used motivational interviewing. The studies that targeted alcohol only did show reductions in drinking, in much as the rest of the literature has been showing, but they showed no carryover benefits to drugs. Those interventions that looked at both alcohol and drugs produced reductions in alcohol and in the use of marijuana and other drugs. So I think that there is some potential, and we're trying to encourage people to do studies to look at screening and brief intervention for both alcohol and drugs in combination. Another type of intervention that's very popular is called social norms intervention. Generally, adolescents tend to think, and college students tend to think, that their peers drink more than they really do. And what these studies try to do is to correct those misperceptions. They believe that those misperceptions lead to a sense of peer pressure for people to drink higher levels of alcohol. And maybe if they can correct those misperceptions, they won't feel so much pressure and they won't drink as much. This is a review that was done in 2015. 52 of the studies were done in the United States, and they did show that there were small, significant reductions associated with the social norms feedback, especially when the interventions were done face-to-face or over the web, with feedback over the web. They didn't find any benefit if there was mailed field feedback or social norms marketing, where there's advertising and newspaper articles that say that college students aren't drinking as much as people think that they are. They felt that these effects, while significant, were small and probably not sufficient that these could be standalone programs, which unfortunately I think a lot of colleges do this and nothing else. So they really think that they ought to be combined with other programs. Now, I wonder how many of you work at colleges or have worked with colleges that have used the Alcohol EDU program. This is probably the most widely used web-based program, educational program about drinking that college students are exposed to. Over 500 colleges now require that their students enroll in this program and take this web-based course as a condition of matriculation. We funded a randomized trial that looked at 32 colleges that had never done any kind of web-based intervention, and half of them were assigned the Alcohol EDU program. Those who were assigned to that program were interviewed during the summer before they enrolled in college, and then again in the fall semester and the spring semester. Those who weren't exposed to the program also were interviewed at the same times. And what they found was that those who took the program had reductions in drinking during the fall semester and related problems, but by the spring semester these differences between those exposed and not exposed to Alcohol EDU had evaporated. So in what I thought was a very even-handed discussion, the authors said that what they ought to consider going forward is doing programs with booster sessions, and that it needs to be not a standalone program, but integrated into a more comprehensive set of programs. It strikes me that it's kind of like when the Wright brothers first flew at Kitty Hawk. They didn't fly very high and they didn't fly very far, but at least they flew. And if we can continue to improve upon this program, like the aeronautics industry has done in improving our aviation and our airplanes, then I think that there is a potential to reach larger numbers of people with more profound effects. Now, another type of intervention is at the family level. Probably the strongest single predictor of drinking and alcohol problems among adolescents and college students is the behavior of parents. If our national surveys indicate that parents who drink compared to parents who are abstainers are twice as likely to have children who will engage in binge drinking and meet alcohol use dependence, alcohol dependence and abuse criteria. a lot of parents think that it's a good idea to provide alcohol to their kids at home so that they can learn to drink under supervision and learn to drink in moderation. They think maybe this will take away the sort of forbidden fruit feeling about alcohol. Well, this has been studied, and the CANAC a couple of years ago reviewed 22 studies, both cross-sectional and prospective studies, and they found that parental provision of alcohol to their children at home was generally associated with increased alcohol use by their children, increased heavy episodic or binge drinking, and higher rates of alcohol problems. And they said the data were equivocal that there was any protective any protective effect of parents giving alcohol and having their kids learn how to drink under their supervision. There have been a number of family intervention studies that have been shown to be effective. Perhaps the most effective, Dick Spoth did the Iowa Strengthening Families program, designed to improve parent-child relations, strengthen family communication, and coping skills. Some sessions done with adolescents or college students alone, some done with parents and children together. And what they found, if you begin the interventions when people are in middle school, by the time they become high school seniors, those exposed to the intervention were 1/3 less likely to report drinking to intoxication. And follow-up studies indicated that the results were still persisting at age 21. So that NIAAA is now funding a multi-state implementation of that family-centered approach. A lot of parents think that when their children go away to college, that they lose their influence over them with regards to their drinking. And the study I'm reporting here on this slide was a study that tried to test whether parents can continue to have an effect. Rob Teresi, funded by our institute, has developed booklets about how parents can talk to their children, be they underage or in college, about alcohol and about how to avoid excessive alcohol use. What they did in this study was they went to a university out in California, and they sent half of the students who had been accepted into that university, their parents were sent a booklet about how to talk to their children about alcohol, and they were asked to make sure that they had read the book. They were asked to rate what they thought about the book, and it turned out that about 3/4 had in fact read the book. And when they compared those who were sent the booklets to those not, those who were sent the booklet, their children were less likely to start to drink if they hadn't been drinking already. And even if they had been drinking, particularly among women, their drinking was less likely to escalate to the extent that of the children who had not, or the college students who had not been exposed, whose parents had not been exposed to this book. There have been several replications of this since this study came out, and clearly this is a promising area that indicates that indeed parents can continue to have influence over their children with regard to alcohol when they're in college. Now, in addition to these family-based interventions and school-based interventions, there are a whole host of environmental policies that we know can reduce drinking and drinking and driving. This is a long list of studies that have found that different types of drinking and driving policies can reduce drinking and driving. The one that's being pushed the most arduously right now by Mothers Against Drunk Driving is ignition interlocks for all offenders, first-time and repeat offenders. There have been studies in the past year or two in the American Journal of Preventive Medicine and the American Journal of Public Health. Kaufman and McGinty were the lead authors on these, and they find that these laws, when passed, have general deterrent effects and reduce alcohol-related traffic deaths by 8 to 9%. Very similar to the effects of lowering legal blood alcohol limits down to 0.08 for adults. There also are environmental policies, raising the drinking age to 21, reducing alcohol outlet density, and increasing the price of alcohol. Adolescents and college students have oftentimes lack discretionary income, so they're particularly sensitive to increases in alcohol price. Now, I'm going to focus a little bit on the age 21 law because that had a broadside challenge to it a few years ago. There was a group of 130 college presidents who said maybe we ought to consider the drinking age of 21 and lower it down to 18, give people under 21 drinking licenses, teach them how to drink safely, and tell them their license to drink would be taken away if they don't engage in safe or moderate levels of drinking. One of the arguments they used was that they said that the age 21 law prompts people to drink in unsupervised circumstances, drives drinking underground, and as a result, without supervision, they're more likely to engage in explosive levels of drinking. Well, when we looked at our national surveys on this, it turns out that the people who are most likely to drink 10 or more drinks on an occasion, or 21 or more drinks, the equivalent of a fifth of hard liquor, they tend to be the ones who are 21 to 24. Those who are 18 to 20 are less likely to engage in those drinking behaviors, and it's particularly the ones who are in college that are most likely to engage in this explosive drinking, the ones of legal drinking age, not the ones below the legal drinking age. Another argument is, oh, if only we could teach our kids to drink like they do in Europe. They got lower drinking ages there, and they don't have the kinds of alcohol problems that we do. Well, this slide is a study of 30 plus European countries ask the same question as we ask in our National Monitoring the Future study. The question that I'm looking at here is, these surveys were done with samples of 15 and 16-year-olds. Did you drink to intoxication in the past year at any time? And we can see here on the far right, about 26% of U.S. 15 and 16-year-olds said that they had done so. But if you look at the countries, the European countries to the left, it looks like all but 2 or 3, maybe 4 of those countries have a higher percentage of 15 and 16-year-olds who are drinking to intoxication than the United States. So the notion that the Europeans have figured this out, how to have responsible drinking among adolescents, is simply not true. They compensate by having higher age of driving licensure and lower legal blood alcohol limits that we have in the United States. And we could probably learn from them on that, but I think they could learn from us when it comes to legal drinking age. Compared to other regions of the world, Europe has the highest per capita alcohol consumption, the highest percentage of deaths that are attributable to alcohol, and the highest prevalence of alcohol use disorders. And if we look at the data on this, as I mentioned, even among college students and among high school seniors, we've seen tremendous reductions in binge drinking after the legal drinking age was raised to 21, and marked reductions in alcohol-related traffic deaths among drivers who are under 21. No age group has experienced as remarkable a decline in alcohol-related traffic deaths as those in the 16 to 20-year-old age group. CDC reviewed nearly 50 studies on drinking ages and found that back in the 70s, when the drinking ages were being lowered, there was an increase in alcohol-related traffic crashes in the targeted age groups, and then when the drinking ages were raised, there was about a 16% decline. Jim Fell, one of our grantees, did a study where he controlled for all kinds of potential confounding factors and found that he looked at the ratio of drinking to non-drinking drivers in fatal crashes. And he too found that raising the drinking age was associated with a 16% decline in alcohol-related traffic deaths among those under the age of 21. He also found something else that's quite interesting, and that is that laws aimed at adults, lowering the limit to .08, administrative license revocation, safety belt laws, those laws aimed at adults also had produced reductions above and beyond raising the drinking age to 21. It strikes me that if you tell young people that they're the problem when it comes to alcohol and don't acknowledge that adults could be part of the problem too, they'll review it as being hypocritical and won't be as likely to, won't be as responsive to laws trying to reduce their drinking. Bill DeYoung at Boston University has done a review of the minimum drinking age, and I think the title, this was published in Journal of Studies on Alcohol and Drugs in 2014, the title says it all. Case closed, research evidence on the positive health impact of the 21 minimum legal drinking age in the United States. The National Highway Traffic Safety Administration estimates every year 500 to 1,000 deaths are prevented as a result of the drinking age being 21. Over 30,000, if you look at it cumulatively, lives have been saved. I think it's an underestimate because they focused only on traffic deaths and they didn't look at other types of problems that are associated with underage drinking. And they didn't look at the carryover benefits of the drinking age of 21. There have been two national surveys that have been studied by Norberg, and they compared people who grew up in states where they could drink before they were 21 to those who had to be 21 before they could legally drink. And they looked at them when they were adults, average age around 40. Those who grew up in states where they could drink legally before 21 were more likely as adults to meet alcohol use disorder criteria and drug use disorder criteria. More recently, Plunk looked at compared people who could drink legally before 21 to those who had to be 21, and those who were able to drink legally before 21 were more likely to die from alcohol-related liver disease, other liver disease, and oral cancer. So we now are getting evidence that there is a carryover benefit of delaying onset of drinking. Certainly our national surveys have shown us that the earlier people start to drink, it's almost a stair-step increase in the likelihood of experiencing alcohol dependence. And this has been found even in studies of identical twins where they share the same genetics, but one twin for some reason or other started to drink earlier than the co-twin. And these studies have found that those who start drinking earlier are more likely to develop dependence than the co-twins who start drinking later. We found that they not only are people who start to drink early more likely to develop dependence at some point in their life, they're more likely to develop it at a younger age and experience chronic relapsing dependence characterized by more episodes, multiple episodes, and more symptoms. A few years ago at a CADCA national meeting, a woman came up to me as I was presenting these findings and told me about her son, Brian Paul McKelvey, who had developed a serious drinking problem by age 16, and they persuaded him to go into treatment. He was doing well. He was in recovery when he was struck and killed at age 19 by a repeat offender drinking driver. So what this tells me is that while treatment it can be effective and can improve people's lives who have alcohol problems, we can't treat our way out of this. That's not the sole solution. We've got to change the environment that prompts people to be engaging in these risky behaviors after drinking to begin with. Earlier drinking onset has been found by the Surgeon General's report to relate it to motor vehicle crashes, unintentional injuries, physical fights after drinking, injuring oneself and other people after drinking, and motor vehicle crash involvement because of drugs. I like to dedicate my articles to people because and to people who have been the victims of alcohol misuse, often other people's alcohol misuse, because it shows it's not just numbers that we're talking about. These are real people. I mentioned this to a woman when I was organizing a conference on young people and drinking. She was helping to co-organize the conference. And when I told her why I like to dedicate my articles to people, all of a sudden tears welled up in her eyes. And what had happened is she had lost her son, Michael Timothy Wilder, 18 years earlier to a repeat offender drinking driver. Well, I thought I was being sensitive, but I don't think I fully understood the enduring pain that people can experience because of alcohol misuse by other people and the effects that it has on their own family members. It hit me between the eyes like a 2x4 that I just didn't fully appreciate how enduring the pain and suffering can actually be. Subsequent studies have further found that early onset of drinking can contribute to suicide, violent behavior, criminal behavior, prescription drug misuse, which is leading to this drug epidemic that we're talking about, overdose epidemic, risky sexual behavior, and adults injuring themselves and other people after drinking. Now, why am I belaboring all of this? Why is it important? It's important because in the United States, injuries are the leading cause of death among young people ages 1 to 44, and alcohol is the leading contributor to those injuries. So what we're talking about is the leading contributor to the leading cause of death among young people in the United States. It's not advancing. We'll see if we can get this to advance. Okay, there are still some unanswered questions about the legal drinking age of 21. In a lot of states, parents can legally provide alcohol to their kids, and in most states, people under 21 can serve alcohol. So I think we need to find out what would be the impact of reducing those loopholes. And I think we also need to learn about extreme binge drinking. I reported earlier about extreme binge drinking among college students. The Monitoring the Future study has identified that it's a problem with high school seniors as well. About 5% in one survey reported drinking 15 drinks or more on an occasion during the past 2 weeks, and there was no change over time in that from 2005 to 11 in the percentages reporting that behavior. At that level, people have a 500 increased risk of, if they're driving after drinking, of being involved in a fatal crash, and at least a 50% chance of blackout. And we know that drinking to those levels suppresses the brain stem and reflexes and gagging, and can lead to overdose. We have learned that social host liability laws are effective in reducing drinking and driving. And Jim Fell recently did a study where he looked at 20 different laws aimed at reducing underage drinking and driving. In his analysis, after controlling for several potential confounding factors, 9 of them independently produced significant reductions in alcohol-related traffic deaths. And this is the list of the different types of laws. He concluded that collectively, those 9 laws prevent over 1,000 deaths per year. And not all states have all of them. And if all of them adopted all 50 states adopted all of those laws, we'd save another couple hundred lives every year in the United States. Now, I'll end up by saying, is it enough to pass these laws? No, it's not enough to pass these laws. This slide is a classic study that was done in Washington about 15 years ago, where 2 young people under 21 were given money and told to try and purchase alcohol. And 98 times out of 100 in the nation's capital, they were successfully able to buy alcohol. So what that means is that it's not enough to pass these laws. There's a whole process of police and court enforcement and public education about why we have the laws and how the laws are going to be enforced that are necessary to change attitudes about alcohol and to create deterrence and to reduce the drinking and driving behavior and alcohol-related fatal crashes. That's best done at the community level. And we have studied numerous multi-component community interventions that have tried to address these types of problems. And the good news is that we found that these multi-component multi-component community interventions can reduce alcohol problems, and specifically we found that they can reduce them amongst the hard-to-reach college population. What these programs do is they coordinate multiple city departments, have clear, measurable objectives and strategic plans, combine law enforcement and education, include expansion of screening and early intervention, use data to plan and evaluate, and they involve private citizens. This is a booklet on how to do these things that was put together by CADCA and Mothers Against Drunk Driving. On the college front, McCart did a study in West Virginia where they worked with the university and surrounding community, sobriety checkpoints, saturation patrols, multimedia campaign to talk about the enforcement and increased enforcement. They did roadside surveys in the intervention and in a comparison community before and after this intervention went into effect, and they found that the intervention, they did breath tests of drivers stopped at random. The intervention communities achieved lower levels of blood alcohol levels of drivers after the intervention was implemented compared to the control communities. Bob Saltz did a fantastic study out in California, went and worked with the public university system and did a randomized different universities out there to receive an intervention where they looked at where binge drinking episodes were taking place. It tended to be at off-campus parties. And then they did interventions that didn't focus on trying to change individuals' drinkers' behavior, but rather they worked with the people who were holding off-campus parties. They had a social host campaign. They had a DWI checkpoints, police patrols targeting these parties, and social host ordinances penalizing hosts of parties that stimulated complaints to the police. And they found that they were able to achieve in each university in the intervention about 10,000 fewer incidents of intoxication during the first year that program was implemented relative to the comparison colleges. Wolfson did a similar multi-component community intervention in North Carolina and found that these policies and programs, environmental policies and programs, not only can reduce harms that college students experience because of their own drinking, but it also reduced rates of problems posed that college student drinking posed for other college students, secondhand effects of college misuse, alcohol misuse. So in conclusion, the research points in the same direction. We can reduce college drinking and related problems, and in fact are doing so, and we can do it at the individual level, through social norms and web-based programs, through interventions that target multiple levels, including family-based interventions and multi-component community interventions. And there still are some unanswered questions. Will environmental interventions to reduce availability and programs to expand alcohol screening and treatment, if they're done together, will that be more effective than doing either one alone? Are programs that target both underage youth and young adults more effective than those that target youth only? Are there carryover benefits of programs that target youth? Will these programs also reduce drug use? How can these effective programs be sustained over time? And what types of programs are most effective in reducing problems at the least cost? Let me conclude, though, by saying that we are making a difference. We are bringing college student drinking and alcohol-related traffic deaths down. Tremendous declines. It's a shame that each of you listening on this webinar doesn't get dozens of letters each year from people who you've helped prevent these alcohol-related problems. But as you know, when you're in the prevention field, oftentimes the people you help don't know who they are. But if you look at the data, they're clearly there. So you are making a difference, and I think you should be applauded for the work that you're doing in helping to turn the corner on reducing college drinking and related problems. I always like to end this talk with an encouragement that people read a book that I found very informative. It's called Polio, An American Story, written by David Oshinsky. It was published on the 50th anniversary of the polio vaccine in the United States, and it's about the competition between Sabin and Salk to produce the first polio vaccine. There are a lot of lessons that can be learned from this book. One is the power of grassroots activism at the community level. The people who funded the first experimental study that showed that the vaccine was effective was not the National Institutes of Health, it was the March of Dimes. And the people who initiated the first worldwide effort to eradicate polio was Rotary International. It wasn't the NIH or the CDC or the World Health Organization, although they got on board. It was Rotary International. So grassroots activism can accomplish a great deal. I was actually part of the generation that first received these vaccinations in school. And I remember we feared polio. It struck at random. It killed people. It maimed people. But you know, when you read this book, you learn that in the worst year of the polio epidemic in the United States, there were 55,000 cases and about 5,000 deaths. Much smaller problem than the nearly 90,000 deaths that are attributed annually to alcohol misuse in the United States. So we're trying to grapple with a much more important problem. And I think the other lesson that can be learned from this is that there was sort of the wrong model about how to make progress back in those days. Sabin and Salk didn't like each other. They were fierce competitors, and each of them used to put down the other's vaccine and say it wasn't effective, only theirs was effective. They were vying for credit. Well, you know, in our field, to reduce alcohol problems, there is no single silver bullet. There's a whole multitude of approaches that need to be tried. My dad, by the way, knew both Sabin and Salk, and one time was in Rome, Italy, and the front page of the Rome newspaper had a story about Sabin and all that he had done. Well, the fly in the ointment was that it was Salk's picture that they had in the paper. So my dad bought multiple copies of the paper and sent them to both Sabin and Salk, sort of to kind of stir up the pot. But the lesson here is not that we need competition for credit. Rather, what we need is cooperation. We need cooperation at the federal level, at the state level, at the local level, across multiple departments of city government, with colleges and universities, and with the communities that surround them. We need public officials to work with private citizens and private organizations and work cooperatively. It seems to me that it's not competition that we need to be most effective, but rather cooperation. That if we can achieve optimal cooperation, that we'll be more effective in addressing alcohol misuse, which after all is a leading contributor to injury, which is the leading cause of death among young people in the United States, which in my view is sort of the polio of our generation. So there's a little bit of time left over. If there are questions that people have or discussion that they would like to have, I would be welcome to entertain any questions or comments you have.
Thank you so much, Dr. Hingson. That was so much great information. We really appreciate you being with us. We do only have a few more minutes. We have a couple of questions that we'd like to pose to you. The first, Dr. Hingson, does moderate alcohol consumption confer any health benefits when compared to abstainers?
There has been a mixed literature and a debate in the literature about that. There are some who believe that and have reported that people who engage in moderate drinking are particularly less likely to experience cardiovascular disease and death. However, when they have looked at these studies, oftentimes the people who are the abstainers that they're comparing these light drinkers to include people who are abstaining because in the past they've had very serious alcohol problems. So it's not necessarily a clean comparison group. There is planning right now a multi-site randomized trial, experimental study to test out this hypothesis, and I think it probably will require an experimental study to come up with the most definitive answers. Even that said, studies clearly indicate that if you start to drink beyond what I was calling the low-risk drinking limits that NIAAA has defined, that there is an increased risk of cardiovascular disease and death. So heavy drinking clearly poses a problem, an increased risk not only for heart disease but all-cause mortality and many types of injuries and illnesses.
Thank you. We have one final question. Are there any studies about the reduction of traffic alcohol-related incidents that take into account transportation apps like Uber and Lyft? And are young people using these options instead of getting behind the wheel or riding with someone who has been drinking?
That's a great question, and I don't know of any definitive studies on that. I'm sure that there are people who are using Uber, or probably before Uber, who were using taxi cabs or safe rides programs to avoid driving after drinking. The important point, though, is that we've made great progress in reducing alcohol-impaired driving. If we look at all age groups, not just those who are 18 to 24 or under 21, alcohol-related traffic deaths in the United States since the early 1980s have been cut in half. There have been at least 300,000 deaths that have been prevented as a result of reductions in drinking and driving. And that's more than the combined impact of increases in safety belt use, airbag use, motorcycle helmet use, and bicycle helmet use. So we are making great progress in that regard. I think it's because most fatally injured drivers are tested for alcohol, and we have data over time at the state level and at the community level, and researchers have been able, because most fatally injured drivers are tested for alcohol, we have a reliable yardstick by which to measure which types of community and state level policy and community intervention programs are most effective in reducing drinking and driving. I am concerned that there's been an increase in driving after drug use. The National Roadside Surveys actually indicate that driving after drinking has been going steadily down for the last 25, 30 years, but the more recent studies have included measures of driving after drug use, and that there actually are more drivers on the roads in the weekends at night in the United States who are driving after drug use than driving after drinking. The epidemiologic and experimental studies that have looked at this have identified that there are increased crash risks in driving after many different types of drugs. Not as great as the risk of driving with a blood alcohol level of 0.08 or higher, but the highest risk actually is when people are driving after simultaneous alcohol and drug use. And I'm concerned that unless we start to bring the driving after drug use and driving after drugs in combination with alcohol, unless we learn how to more effectively prevent that some of the benefits that we've been having as a result of reductions in driving after drinking may begin to erode. So we can never sort of claim victory on these things. There's always a new generations of drivers that are getting into the driving pool, and we have to constantly be vigilant and redouble our efforts to reduce all types of substance use related impaired driving.
Well, Dr. Hingson, thank you so much for your presentation today. We really appreciate you sharing with us. We just have a few announcements that we would like to share with all of you. September is National Recovery Month, and the Higher Education Center has a couple of offerings in celebration of Recovery Month. And the first is our Recovery Learning Collaborative, which is a series of 6 webinars. The first starting on Friday, all about how to build and sustain collegiate recovery supports on your campus. This is ideal for campuses who maybe are exploring the beginnings of collegiate recovery efforts on your campus, as well as those who are new to collegiate recovery, and a great refresher to those who have been involved in collegiate recovery efforts for a number of years. If you are interested in learning more about the Recovery Learning Collaborative, you can email us at hecaod.org at osu.edu. We also encourage you to join us for our Recovery Month Twitter chat. We're partnering with Transforming Youth Recovery on Tuesday, September 26th at 2 p.m. Using the hashtag StudentsDoRecover. So those of you who are interested in learning more about recovery or involved in a collegiate recovery effort on your campus, please join us for our Twitter chat. And finally, please connect with us at the Higher Education Center. You can visit our website at hecaod.osu.edu. This webinar was recorded, and the slides as well as the recording will be posted on our website by the end of the week, as well as our YouTube page. Again, I want to thank Dr. Hingson for sharing his expertise with us. Thank you so much for all of you joining us, and we hope to speak with you soon.
Thanks, Cindy.